1.
Depression has likely been around since the beginning of time. In fact, Aristotle first wrote about it in his writings, describing it as a state of melancholy. According to the Journal of Pediatrics, the number of teens who have experienced a depressive episode in the last 12 months here in America increased 37% between the years of 2014 and 2015, showing a dramatic rise. The RAND Health Administration, which is one of the most trusted administrations for public health in America, stated that depression can impair teens' functioning in school, among peers, and in family life.
In addition to hindering daily life for adolescents, 9% of suicides are linked to depression. Also, suicide is the third leading cause of death in adolescents, as stated by the Administration and Policy in Mental Health and Mental Health Services Research in New York, further proving the need for increased awareness and better treatment for depression in American adolescents.
Between the years 2000 and 2011, internet usage in the United States has increased by 257%. The internet has really revolutionized many aspects of society, and this adolescent age group has experienced a much different coming of age than their older peers. The internet overall has been a positive addition to our society. However, a study conducted by professors at the University of North Carolina, Chapel Hill, found that this generation is much more susceptible to internet addiction, which has many adverse health effects, including depression.
According to this graph, internet usage across the world has increased dramatically in the past 25 years, but in the United States specifically, it has increased by 500 million in the last 25 years.
We found that there were three major barriers to treatment, including stigmas, financial need, and access to treatment. Over half of adolescents experience a depressive episode, but don't end up contacting anyone about it. Only 21 to 34% actually receive medical attention, and many teens are afraid to go to get help due to confidentiality concerns.
Another barrier is the need for financial aid in this department. A substantial portion of the healthcare costs for this age group is coming specifically from depression treatment. However, as the expected number of depression recipients rises and depression rate rises in general, the average rate of diagnosis is predicted to go down, meaning that more and more money will have to be spent on depression treatment. And with this, there's a little bit of a gap in data as well, as in the diagnosis rate and the treatment rate are not lining up.
The last barrier is access to treatment. Many parents are not informed of the symptoms of depression in teens today because it's changed so much since when they were in high school. And they overlook depression that their children are experiencing.
Whenever we were coming together to discuss solutions, we thought that in order to reach all aspects of this problem, we needed to start with solutions on a small scale and then expand them to reach out into the communities. We think a sound approach to this problem would be to start with increasing depression literacy in the classrooms, improving school counselors to provide emotional support along with the academic support they already provide, and increase treatment accessibility to communities.
This depression literacy in classrooms would work to improve awareness on a small scale in a low-pressure environment. This encourages comfortability with the subject of depression, and it opens up avenues for students to realize if they are showing signs or if a friend of theirs is showing signs of depression. This would take place in mandatory health classrooms because every student must take health in order to graduate. And then other subjects such as math and English that students need to graduate but also need all 4 years, those teachers would take minor training in depression acknowledgement. This continuation would help kids from the beginning of their high school career to the end of it.
Because children have been exposed to society centered around the internet, they are much more likely to suffer from internet addiction, and therefore, for them to receive the treatment, action needs to be taken in schools where the majority of children spend most of their days.
In this study by the American Department of Public Health, led by Dr. Karen Schwartz from Johns Hopkins Hospital, this American literacy program was done on a number of schools, incorporating depression literacy and with a goal to reduce stigma towards depression in a health classroom environment. And in the study, 46% of teachers had at least one student come to them with concerns of their own mental health or the mental health of a friend, proving the successfulness of this study and program.
This will of course face opposition from many schools, as in the strict adherence to standardized testing. Depression isn't something that can be standardized test, and that'll face adversity. However, it'll also be difficult to enforce on a national scale, as many state education departments will disagree.
In addition to depression literacy in classrooms, we also came up with improved counselors in schools. Many counselors in high schools today just help students with the academic aspect of school, and a lot of times kids don't have anyone to talk to. So we think that counselors should be able to provide more help for the mental illnesses that some kids are experiencing, rather than just help getting into college.
This program will be devised through private talks, which will be accessible to any student who feels that they need it, and also will be available upon teacher requests whenever a teacher notices any unusual or notable increased signs of depression in students.
We also came up with an anonymous helpline that kids can ask questions and express their feelings to counselors anonymously and get answers and feedback with their just different issues that they're experiencing. And we also thought about putting it in a student newspaper, just so other kids who maybe aren't brave enough to come with their feelings and questions can read what other people are thinking too.
However, in large schools, there's a disconnect between counselors and the students there, because there are too many students for counselors to have enough one-on-one time with each and every student. However, if more resources are put into hiring more qualified counselors, this problem at larger schools could be diverted.
We propose that students could be referred to mental health treatment by counselors or teachers who would now be more prepared to do so because of their better mental health status. This would not be the only way to receive treatment, but it would be a way to initiate the process. Students could be, students who qualify for your reduced lunches or a similar program would be able to also receive reduced prices on treatment.
One of the limitations with this is the disparity between mental health and physical health on insurance plans. And so organizations like the National Alliance on Mental Illness are working to find more funding and support in closing that disparity between the two, mental health and physical. So we need more organizations to close that disparity and reach a parity between mental and physical health.
Depression is not an event for stagnation. In fact, by 2020, depression will be the second leading cause of death in America, right behind heart disease, the #1 killer. Thank you.
Katie, how did the group decide to include Carly's perspective, lens, or conclusion into the overall presentation?
Carly had the scientific lens, so depression is, we found, or her research proved to us that depression comes from chemical imbalances, but also the environment and that people are around. So it's really important to us to note her findings, because we wanted to incorporate her information in a classroom setting and see what changes we could make based on the scientific lens.
Carly, discuss how the content of your team's presentation was changed as a result of group discussion.
Before we started group discussion, I think we were all looking for a way to just stop kids getting depression, like before, like it happened, like stop the race. But after coming together, we realized that from Clayton's lens, that depression has always been around. And rather than looking at the many different ways that depression could be, is more prevalent in this generation, we should look at ways to reach this generation for treatment, because treatment is so proven to actually work.
Sophia, what is an example of a compelling argument from one of your peers' individual reports that you decided to exclude from your team's presentation, and why?
We decided to exclude Carly's argument about the chemical imbalance because we focus more on the environment that students are around and why that causes, or at least possibly lead to depression.
Jonathan, reflecting on all of your colleagues' work, which one had the greatest impact on your overall understanding of the problem that your group identified?
I would say Clayton's historical lens lended the most to that. Like Carly said, his lens brought us to the conclusion that depression has always been around, and it had our project focus less on quote-unquote solving depression and more on bringing accessibility to treatment.
Clayton, having finished your project, what, if anything, would you consider to be a gap in your team's research that, if addressed, would make you feel more confident about your team's conclusion?
I feel like a lot of ours centers around the ethical distribution of treatment for depression, whereas I feel like a lot of information could be mined from the scientific lens of what may cause it and how that can be tactically treated in schools. Not just the right to supply treatment, but also how people can go about supplying treatment.